So in the last video, I talked about the ways that you can alter your diet to prevent diabetes. And what I want to do in this video is talk about what you do once you actually have full-blown diabetes, because nutrition has a role to play there too. So once again, we're going to talk about the two different types of diabetes. But now we're going to talk about insulin dependent and non-insulin dependent, because as we discussed before, when people have type 2 diabetes, sometimes they become insulin dependent, especially after they've had it for a while, and so then how it's treated looks a lot like type 1 diabetes. So if you are in the phase where you have non-insulin dependent type 2 diabetes, it's still early in the disease. Of course, we talked about how you can prevent the onset of full-blown diabetes by lowering your weight. And all you have to do is increase your physical activity to 150 minutes a week and lower your fat intake, reduce your total weight by 7%, and that's enough for 50 to 70% of people to keep them from progressing from prediabetes to diabetes. But if for whatever reason you have not been successful, if you're one of the unlucky ones for whom that didn't work, and you have diabetes, then what you can do to use nutrition to help you deal with your disease is to think about the fiber that's in your diet. As when we talked about glycemic index, we talked about how anything that you can eat that slows down stomach emptying when you have carbohydrates can smooth out the blood glucose, and when you have type 2 diabetes, you have some ability to take up glucose from the bloodstream. So if you just slow it down, then you can keep your blood glucose levels from spiking. And of all the additions to the diet, it's fiber that has the biggest effect on slowing the release of glucose from carbohydrates into the bloodstream, more so than any other category. So increasing dietary fiber is one of the recommendations. Now, if you have insulin-dependent diabetes, then things get a little bit tricky, because all of the carbohydrates that you take in have to be matched to the amount of insulin you inject. And so that, in order to keep blood glucose levels within the normal range, and that's the goal. And the reason for that is that there are a lot of complications that come with diabetes that can be avoided, or at least your risk can be reduced, if you can keep that blood glucose within tight levels, close to normal as possible throughout your life. Then you could possibly not come down with things like kidney damage and peripheral neuropathy, losing your eyesight, all of those terrible things, and also heart attacks that people who have diabetes have an increased risk for. So you can live a longer, healthier life if you can keep those blood glucose levels within a tight, normal range. The other thing to think about is, while you're giving yourself injections of insulin, but if you have too much insulin, the blood glucose levels could drop too low, and you can actually go into hypoglycemic shock, where the blood glucose levels are so low that your brain starts to suffer. So that is what nutrition can do for you. So if you are an insulin-dependent diabetic, there are some things, some tools that you have at hand that you have to keep your blood glucose levels constant. First of all, most diabetics have to be able to test their blood glucose levels. There are easy little machines now where you just prick your finger and load it onto there, and right away it will give you a reading, and you can put these in your pocket and carry them with you. The other thing that you have to have is two different types of insulin, a long-acting insulin and a short-acting insulin. And then you also need to have some way to know how much carbohydrate there is in your diet. One way to do that is to use the nutrition labels, so they'll always tell you the total carbohydrates. And of course, because fiber doesn't generate any glucose, it isn't involved in the equation. So the carbohydrates that you're interested in is total carbohydrates minus dietary fiber. And that will give you all sugars and all starches that are in the food. There's another method, though, that you can use to control the amount of carbohydrate in your diet, and that's called the exchange lists. So as to which one you use, it's something that your physician will choose for you and make sure that it works for you. So both methods are available, and we're going to talk about both of them. So how do you take those tools and use them to regulate your blood glucose? Okay, first of all, it's those two types of insulin, long-acting and short-acting insulins. What people will do is either once or twice daily, most of them twice daily, they will give themselves injections of a long-acting insulin, and that provides sort of like a baseline of insulin. So this graph here shows you the insulin activity that's going on. And remember, insulin activity is the ability to get the blood glucose from your bloodstream and into your cells. So twice a day they will give themselves, once in the morning when they wake up and once at night before they go to bed, an injection of a long-acting insulin. And then before each meal, in addition, they will give themselves a pre-meal injection of a short-acting insulin. And the dose that they give for these short-acting insulins will be based on how much food, how much in particular carbohydrates, they plan to eat in that meal. And if it's a super short acting insulin, it will only last like an hour or two, so you need another one before lunch. But there are others that are intermediate where you can give yourselves one injection to cover breakfast and lunch, and one injection to cover dinner and a midnight snack. All right, so the diet planning part of it, of course, is the nutrition. When you have type 1 diabetes, you have to be able to know how much carbohydrate you have in your diet. Imagine that you are going about your day and everything needs to come to a halt while you look through the foods that you're planning to eat. Let's say you're standing in line in the Commons and you're looking at a sandwich in the what is that place called where they sell the sandwiches? You know what I'm talking about. So you're looking at the sandwiches and you have to go back and sit down and calculate how much carbohydrate there is in that sandwich so that you can give yourself an injection and then go back in line, buy it, and eat it. That's what's involved. So there's two ways that people who are insulin dependent can go about doing this daily task. One is the sort of more flexible approach, and that's carb counting. And the other is more rigid, but in some ways, some people find it easier, and that's using something that are called exchange lists. So in carb counting, what you do is you basically eat what you want, but you have to calculate how much carbohydrate you're getting in that meal, and then you vary the amount of insulin that you give yourself to match the amount of carbohydrates that's in that insulin. As long as they match, and as long as you're not doing anything else that's going to vary your insulin needs, like if you're under stress, if you're sick, if you are exercising, all of these things can vary your insulin needs. So as long as you take all that into account, that works well, and you can eat what you want. Using the exchange list, the idea is that you have a plan for what you're going to eat every day, and you stick to it. And as long as you follow that plan, you don't need to vary your insulin. You have one dose, and you don't have to think about it, and it's the same every day. So what's involved in carb counting? First of all, you need to start by testing your blood glucose levels before meals. So you have to go into the bathroom or someplace, where people won't be watching you, sticking your finger, and then do a quick glucose blood test. And then from that, it will tell you how much excess grams of carbohydrate there is in your bloodstream that you need to get into the cells. So how much do you have left over above what's considered normal? Then what you need to do is to count the units of carbs in the meal that you anticipate eating. So then after you know those two things, then you calculate how much insulin you're going to need by adding up the grams, let's say, of extra glucose that you have in your bloodstream, plus the grams of carbohydrates that's in the meal that you're about ready to eat. And then there's formulas. And the formulas vary. There's different methods. And most formulas need to be customized for you in particular. There are adjustment factors that your doctor goes through with you. But an example calculation might be something like, for every 10 grams of carbs that's in my blood or in my diet, I need to inject 1 unit of insulin. Then you measure out 1 unit of insulin, inject it, and then you go and you eat whatever you've planned to eat until the next one. So in the exchange list, on the other hand, what you do is you give the same injection dose at the same time every day, and then you plan your meals to occur at the same time, and you have fixed portion sizes of those meals. You do have flexibility with respect to what you eat, but for each food that you eat, you have to know what is the right portion size to deliver the fixed amount of carbs. So the insulin is constant, but the dietary carbs have to be planned. So what are exchanges? Exchanges are lists of foods that are grouped together. And unlike the typical groups that we use, like meat and fruits and vegetables and things like that, they are grouped based on their macronutrient profile. So it turns out that many of the things that we would call, for example, meats, have very similar macronutrient profiles. So in many ways it works out to be the same, but there's some exceptions. And the place that you see it is when you deal with carbs, because of course that's exactly what we're worried about. So starch. Starch is those things that come in pure starch form, cornstarch, things like that. But it's also starchy vegetables and grains and things made from grains. So any carbs that are not starch, for example, candy or sugar that you would add, are the other carbs. Fruit is in a category by itself. Milk is in a category by itself. And these 1, 2, 3, 4 groups are the ones that have carbohydrates in them. Then they have the vegetables that are not starchy. And that's the prime difference between the typical food groups and the exchange food groups, is that vegetables are broken down into starchy and non-starchy. And then you have your meats and your fats. There's also a category that's called free foods. And these things, because they don't change your blood glucose, you can eat as much of them as you want, and it doesn't matter. And they also don't have very many calories. So things like chewing gum is in there, lettuce is in there, things like that. So once you've got the groups together and you sort of know what's in each group, then the exchange lists, and you have to go look this up, tells you the serving size for each food within that category that will deliver the same number of carbs and the same number of calories. Okay, so once you've got those serving sizes and groups, then you can choose within any one of those categories anything that you want. So some examples. Let's look at what is considered one exchange, and let's just look at the category of starches. In the starches category, all of the portion sizes are adjusted so that they are exactly 80 calories each. They have 15 grams of carbs, and if you do the math, 15 times 4 is 60 and calories, and then the remaining, excuse me, that should be kilocalories, the remaining 20 kilocalories is made up with protein or fat. And the numbers here, 0 to 3, reflects the number of kilocalories that you're going to get from that source. So by applying these rules here, it works out that a quarter of a large bagel has 80 calories and 15 grams of carbs. So if you want to eat a bagel, you got to cut it into quarters, and you eat 1/4, and that's considered a starch exchange. On the other hand, if you want to eat a corn on the cob, you can do that, but you can eat half of a corn on the cob, and that is equivalent to a starch exchange. All right, so how you go from these lists to doing your meal plan is that every day you have, say, 1,500 kilocalories. So a dietitian will sit down with you and say, here's your number of kilocalories that you have that's appropriate for your gender, age, and BMI. And you can have 8 starch exchanges, 3 fruit exchanges, 2 milk exchanges, 2 veg exchanges, and 5 fat exchanges to distribute over the day. However, the ones that have carbohydrates in them have to be, you can't have them all at once, because you're trying to keep your carbohydrate levels in your bloodstream kind of even. So then the dietitian will lay out a plan for you that says, for breakfast every day, you are going to eat 2 starch exchanges, 1 fruit exchange, 1 milk, and 1 fat. And that sounds kind of cumbersome, but if you look at what that works out to be, that works out to be kind of what it is that you would eat in a typical breakfast. So you've got your cereal with milk, you've got a toast, slice of toast with margarine, and then some OJ. Very typical breakfast. And so the day goes on. One thing that you'll notice, though, is that the portion sizes here are really small. So 2 ounces of pork chops. 2 ounces is 2/16, 1/8 of a pound. So if you go into the supermarket and you buy one of those plastic packages of pork chops, you'll probably get maybe 4 pork chops in a pound. So that's half of one of those pork chops. Okay, so really tiny portions. All right, so carb counting versus exchange, which is better? What do you think? It really is a matter of opinion, and what works best is what works best with your life. Here's the experience that people have. Carb counting is favored by most dietitians who counsel individuals because of the flexibility. It gives people who have been hit over the head with, you have this disease and for the rest of your life you're going to have to do all these things. It gives them some freedom. They can eat what they want, and then they can use insulin to make up the difference. So because it gives them the flexibility, they like it better. However, you have to be really on it, and you have to be able to do these calculations. So you can imagine that this is not the best thing for children. They, are not as responsible. They don't do these calculations, can't be counted on to do that. So if you're a child and you have type 1 diabetes, which most type 1 diabetics are, the more likely thing is that your diet will be planned for you. So exchange planning is used where a person has a controlled diet. So it's especially useful in institutional settings where you don't want to have to be going around to your nursing home population and doing blood glucose testing on all the people who have diabetes, and then telling them what portion sizes they can have or what they can choose. Instead, if you put together on a cafeteria tray a diabetic meal, and you have control over what goes on that plate every day, then the nursing staff can just give the same injections to everybody the same day. So it's individualized by person, but it's not going to be individualized according to meal because everybody in the institution is getting the same meal.